Hello, and welcome to the Clinical Liver Diseases video series. Clinical Liver Disease is an official digital learning publication of the AASLD. My name is Avesh Thuluvath, and I am an assistant professor of medicine and transplant hepatologist at Columbia University Medical Center. Dr. Elizabeth Verna and I are authors of the review titled Deciphering an Expanding Array of Clinical and Research Frailty Measures in CLD. Frailty is a clinical phenotype that is prevalent in patients with cirrhosis, a disease characterized by accelerated physiologic aging. Frailty is now widely accepted as a critical predictor of pre- and post-liver transplant outcomes, which has led to an increased emphasis on the development of accurate and objective measures of frailty. In this review, we outline current methods of measuring frailty in patients with cirrhosis and describe the evidence linking these measures to relevant clinical outcomes. We start by describing some historical context. While the formal construct of frailty emerged in the last decade or so, a quote-unquote eyeball assessment of physical deconditioning has always been part of the liver transplant evaluation. Unfortunately, eyeball assessments are prone to bias and are limited in reproducibility. Moreover, subjective clinical impressions do not allow for accurate assessment of more subtle changes in frailty over time. Some of the first structured measures of frailty implemented in patients with cirrhosis include the Clinical Frailty Scale and the Karnofsky Performance Status, both of which were adopted from other fields of medicine, specifically geriatrics and oncology. Karnofsky performance status scores have been used in large transplant database analyses, with lower KPS scores associated with higher mortality. As we detail in this article, however, KPS scores remain subjective and are therefore limited in clinical utility. We next review performance-based measures of frailty and cirrhosis, most notably the Liver Frailty Index and the Short Physical Performance Battery. Both of these were adapted from the Fried frailty phenotype in the field of geriatrics. The Liver Frailty Index is the most thoroughly validated frailty measure currently available and consists of grip strength measured via a grip dynamometer, chair stands, and balance testing. Measurement of the LFI does not require any formal training or specialized equipment outside of the grip dynamometer and is therefore well suited for both research and clinical practice. Higher LFIs have been shown to consistently predict worse outcomes before and after liver transplantation, including higher waitlist mortality and post-transplant mortality, as well as increased frequency and lengths of hospitalizations. More severe frailty, as measured by the LFI, has also been associated with higher healthcare utilization and post-transplant health-related quality of life. The 6-minute walk test, a measure of aerobic capacity, has also been studied in patients with cirrhosis and has been strongly associated with waitlist mortality. Unlike formal cardiopulmonary exercise testing using bicycle ergometers or treadmills, the 6-minute walk test can be performed with ease in the clinical setting, making it an ideal research and clinical tool. We wrap up the review by discussing remote frailty assessments. Seeing as frailty can change rapidly in between clinic visits, measuring frailty remotely is critical to capturing clinical deterioration prior to the development of significant debility. Recently, telemedicine versions of the LFI and 6-minute walk tests have been adapted to measure frailty remotely. Patient-reported outcome measures, or PROs, such as the PROMIS Physical Function Survey, have also been used to measure frailty. While results of early pilot studies are promising, these remote tools need to be validated further before incorporation into clinical practice. Finally, it is critical to interpret frailty measures in a larger context. For example, as of now, frailty measures such as the LFI have been largely studied in the outpatient setting. It is unclear if inpatient frailty measurement using the previously described tools are an accurate reflection of a patient's underlying physiologic reserve, and if inpatient frailty measures can be used for long-term prognostication. For further details on all of these measures, including associated outcomes and the clinical setting in which they have been studied, we encourage you to reference Table 1 of our review, which summarizes major take-home points on each measure. On behalf of all of us on the CLD team, I hope you found this overview of current frailty measures in cirrhosis useful. For more information about frailty and cirrhosis, please visit www.cldlearning.com. Thank you for watching.